Good afternoon, everybody. Welcome. We're going to go ahead and get started. I know there's some people that are just still coming in, and please, feel free to take your time going through the line and getting lunch, or if people want to get up and get anything during the program, that's fine as well. My name is Donna Gasper-Jarvis, and I am the Director of the Office of Multicultural Affairs and Diversity. And I also work as a coordinator with the UNE Channels Project. And I'm really happy to see so many of you here today and welcome you to our annual Martin Luther King Jr. celebration here on the Portland campus. Each year, the University of New England takes time to recognize Martin Luther King Jr. and our celebration in and around the national holiday. And this year marks a very special occasion. For those of you who don't know or haven't heard, Dr. Martin Luther King Jr., as well as a host of other prominent civil rights leaders of the time, actually visited UNE on our Biddeford campus back in May 1964 when it was still St. Francis College. And they came as part of a two-day human rights symposium, and the campus shut down, and there was conversation and dialogue and engagement in some of the social issues and civil rights issues of the time. And so this year, to honor and acknowledge that historic event here at UNE, we're extending our Martin Luther King Jr. Celebration beyond January, which is very exciting, and we have a semester-long series of events that'll be taking place on both campuses and involving all colleges and schools to look at issues of diversity and equity and justice. And so I encourage you, if you are interested in attending additional events throughout the semester, on the back table by the front door entrance, we have a full calendar of events of all of these MLK Jr. related programs that will be taking place this spring. Also on the back table, you'll find a calendar of our fresh off the press interprofessional education calendar. So I encourage you to pick that up as well, post it on your doors, or take a look at some of the great events that are coming up this semester as part of IPEC. So each year, the Martin Luther King Jr. celebration is really a time to sort of reflect and remember our past, but more importantly, to really apply some of the messages and lessons learned from Dr. King in that period of time to what that means today. For those of you who heard the State of the Union address last night, President Barack Obama talked about this being a year for a call to action and a renewed spirit of citizenship, and communities coming together and working together to really address some of the issues that are facing our times. And that really is what the Martin Luther King Jr. celebration is about. It's about a time for us to think about that call to action, to think about that renewed spirit of citizenship and what our responsibility and role is in addressing the issues of our time. So here today, as part of our Martin Luther King Jr. celebration on the Portland campus, we're going to be looking at health and healthcare reform, and how we come together and talk about and address some of the health disparities and inequities that are facing our most vulnerable populations. So we've invited Starla Hairston-Blanks here. She's come up from Atlanta. Starla is the Director of Health and Promotion and Policy at Community Voices, Healthcare for the Underserved at Morehouse School of Medicine. And she's worked with national urban leagues around the country looking at health disparities, and she's here with us today. And the unique thing about Starla is that she is actually one of our very own UNE students, which is the first time ever that we've had an MLK Junior keynote speaker who's also one of our own. She is in our online program with the Masters of Public Health. And to introduce Starla, we've invited Denise Bissayon, who serves as her advisor and is the director of the graduate programs in public health. So Denise.
Good afternoon. So I'd love to introduce Starla Hairston-Blanks, who is the Director of Health Promotion and Policy at Morehouse School of Medicine. And as Director, Mrs. Blanks oversees the development of curriculum, health education aids, technical assistance, trainings and for community and health workers and project staff, who focus on chronic disease and policy. Additionally, she is charged with the evaluation of numerous nationwide projects related to community health, access to care, health policy, diabetes, and nutrition. To this position, she brings experience working at the local, state, and national levels on health promotion, health policy, diversity, and access to care issues. Mrs. Blanks has worked with the community health workers, coalitions, health departments, school systems, community-based organizations, and national networks on a variety of health promotion initiatives, including, again, diabetes, obesity, tobacco use, and chronic disease prevention. In addition, she has been published in journals such as the Journal of National Medical Association, the Journal of Men's Health, and her writings can be found in several books related to health disparities and social determinants of health. She's a nationally recognized trainer with certifications in public health practice, adult learning, community organizing, smoking cessation, and chronic disease. She holds a Bachelor of Science degree in political science and a master's degree in business administration with a specialization in nonprofit leadership. And she's currently enrolled, as Donna said, in our Master of Public Health Certificate program. Hopefully that will turn into the MPH program. We're working on her here. And she is the first UNE student to be featured as a Martin Luther King celebration keynote speaker. So it's my pleasure to introduce Starla.
Thank you. Good afternoon, everyone. No, I flew all the way up from Atlanta, so I'm going to need a little bit more enthusiasm than that. Good afternoon, everyone. All right, wonderful. I'm glad you guys are all awake. My name is Starla Hairston-Blanks, as they say. I am very proud to be here at University of New England. As has been said, I am a student here. After doing a very long career in public health, if anyone is interested in doing community health, you know that you're walking down the street one day and you say, I think I'm going to work in healthcare. But I don't want to be a clinician. What can I do? I'm just going to start volunteering with the program. And then I turned volunteer work into looking at disparities, and I turned disparities into my passion, and I've been able to turn that passion into my career. And so I'm very proud to be here to share with you a little bit today about some of the work I've been doing around community engagement through health empowerment, because part of what I think we all need to understand as we go forward into our professional careers is that health disparities end up touching our careers no matter what facet or organization, or if you're decided you're going to work in a clinical setting or in a community setting. Health disparities end up touching what we do every day, whether you realize it or not. So I'm going to just talk to you a little bit about community health and engagement and health disparities and health equity. Is that okay with everyone? I'm going to keep nodding at you guys because you're eating. I want to make sure everyone stays awake with me. Okay. These are my learning objectives. Y'all can read those later. Okay, a little bit of introductions. They talked a lot about me, but I want to tell you a little bit more. I am from Atlanta, Georgia, where the temperature today is 12 degrees, and our city has completely shut down because there was a ½ an inch of snow. And ½ an inch. There's 4 snow plows. They don't know where to put them yet, so everything's shut down. I hope I can get home. There are also in Atlanta 71 streets with Peachtree in the name. I'm not kidding. There's literally 71 streets with Peachtree in the name, which means you can actually tell people to go down to Peachtree, turn left on Peachtree, turn right on Peachtree, and it's on your left-hand side. We are home of the largest brand, the largest soft drink brand, Coca-Cola. The home of is also based in Atlanta, Georgia. We also have an abnormally high rate of dental caries and diabetes. We're actually home of zombies. Any Walking Dead fans? They actually shoot Walking Dead outside of our campus, so sometimes we cannot get into our office because there's zombies actually walking down our main street. And this is what that road normally looks like on a real day. We are very bad traffic in Atlanta, which is also why those cars, if you watch CNN, are still sitting on the side of the road because of the ½ an inch of snow. Atlanta is also the home of historical sites. We have a lot of historical sites in Atlanta. We have a lot of civil rights leaders. We're known as one of the birthplaces of the civil rights movement. The beautiful thing about growing up in the Atlanta area and working in Atlanta is that you tend to see civil rights leaders on a daily basis. You know, everyone from the King family to Reverend Joseph Lowry. If you do not know him, Google him. He's wonderful. He's been talking about health policy, health equity since before it was cool. He's been doing this since the 50s. And another thing that comes from Atlanta is Martin Luther King Jr. He's been a great inspiration to me. It's been a great inspiration to many of us who work in healthcare. I was asked today to talk a little bit about health justice and health inequity. So what I thought I would do was start with this quote. How many of you have seen this quote before? Probably everyone. This has been a very popular quote. This quote by Martin Luther King Jr. has been very popular to be used by a lot of health advocates who have been talking about the need for Medicaid expansion. And do you think that it's just that people, due to their income, don't have access to health care? And I promise you that I could talk all day long about the need for Medicaid expansion in red states such as Maine or Georgia, but I'm not going to get anyone in trouble, so I'm just going to focus on health equity. I work for Morehouse School of Medicine. Morehouse School of Medicine is a historical black college and university, called HBCU, which means essentially the School of Medicine that I work for has been dedicated to community service and doing outreach in underserved communities across the country. We do a host of programs. We educate health professionals. We have a medical school, as well as a school of public health, and a school of clinical and biomedical sciences inside of the university. And I have to give them a shout out because they gave me 2 days off of work to come up here to Maine and play in the snow and see all you great people. My role is Director of Health Promotion and Policy. So what does that mean? That means essentially, in addition to the things that you heard in my bio, to make it very short and brief for you, I get the opportunity to work in health disparities every day. Absolutely every day I work in health disparities. And what health disparities looks like on each day can be completely different. On some days I'm working on health disparities because we're working with women who have children who have asthma, and they need to get access to medication. But there's no clinics that are open on the hours that they can reach in their community because the clinic's office hours are normally ending at 5 o'clock. If you live in Atlanta, where we are fortunate enough to have public transportation, to get from your job working at Coca-Cola as a maid to the clinic that's going to be open, it may take a train and 2 buses to get there. Now, how long do you think that would take versus a 10-minute car ride? So sometimes that's what health disparities looks like. Other times we're talking about policy changes that need to take place, or we're looking at inequities dealing with different chronic diseases. So I'm going to talk to you a little bit today about health disparities and health inequality. Just as Martin Luther King Jr. had said, of all forms of injustice, all forms of inequality, injustice in healthcare is the most inhumane. And that's something that we definitely have seen in the recent years. Unfortunately, he made that statement back in 1964. It is 2014, and we're still seeing the same health disparities existing today. So when I talk about health inequality, a lot of people say, now what exactly does that mean? Health equity is what we're really striving for. Sometimes we say, oh, I want to help people get access to care. I want to be a provider in an underserved community so that way I can work with, individuals who don't necessarily have a doctor. But what we're really talking about is we want to make health more equitable. And health equity basically is a principle of public health, and of course we learned this also in our coursework here at UNE, is that all people should have the right to health care, and there should be an equitable system of care, which means you should not get care that varies based on where you live, your zip code, where you're born, or where you work. You should be able to access quality health care regardless of your socioeconomic status. That's the basic principle of health equity. So health inequity occurs when you have someone who you place a value on a characteristic. That characteristic may be their ethnicity, it may be their income level, and based on that characteristic, their quality of health care, their health outcomes come out differently. So that's a whole lot of jargon, but I want to kind of break it down for you a little bit. I have a wonderful colleague at Morehouse School of Medicine named Dr. Kamar Jones, who is a MD, PhD, but she is not an artist, but she did make this graphic that she allowed me to share with you guys. See, just because we have multiple degrees does not mean art is one of them, as you can tell here. This is our nice man. What should we call him? Someone, let's name him. Oscar? Okay, Oscar. So this is Oscar. Oh, community health workers are arriving. Hello, community health workers. They're always out helping the community. I'm so glad you guys are able to join us. So this is Oscar. Oscar is walking down the street. Oh, no. Oscar has just fallen off a cliff. Poor Oscar. What should we do for Oscar? Our current health system says Oscar has fallen off a cliff, so listen, an ambulance. This ambulance will be able to pick up Oscar because he's at the bottom of a cliff, and it'll take him away to a hospital that will treat him for all of the injuries he has sustained on the bottom of the cliff. Tertiary care, which means after something has happened to you, we're going to treat you. In some states, they say, Oscar has fallen off a cliff. You know, we should do something about it. Maybe we should put a net up, a safety net. This net will catch him before he falls off the cliff, hits the ground, and has to be carried away by the ambulance. In other communities, they say, let's build a fence. When we build this fence, that'll keep Oscar from being able to fall off the cliff. And then with all things being equal, Oscar and his friends, they will come up, they will see the fence, they will not fall. If they do fall, they'll hit the safety net. If they fall through the safety net, they'll have an ambulance that will take them away. So all things being equal, Oscar should be taken care of, right? But what if in your neighborhood there isn't a fence? What if in your neighborhood, due to funding or lack thereof, there's no fence that was built? What if in your neighborhood the safety net was intentionally limited, not strengthened enough to catch all the people who are falling off the cliff because Oscar's only one of many? Or what if the neighborhood ambulance has a flat tire or it has to travel a long way to get to you? That is how health disparities occur. Health disparities occur when you have individuals who come from the same community, but unfortunately they're treated differently because of different societal influences. So what we need to make sure we're doing is addressing all the multifaceted reasons that can lead to someone falling off the cliff and treating them once they have. So we call this addressing the social determinants of health. When you address the social determinants of health, you are putting in primary prevention, such as a fence. You're putting in safety nets, such as Medicaid coverage for low-income individuals, secondary prevention, and you're also doing medical care or tertiary prevention as well, tertiary care. So what is health disparities? There's a whole lot of definitions that are available to really tell you what health disparities are, but the basics I can tell you about health disparities is the inequity that comes as a result of some other characteristic that leads to negative outcomes in a community as a result of it. Everyone still with me? Great. So I'll talk a little bit about what contributes to health disparities. Income. It is sad to say, but it is unfortunately true that sometimes your health status is based upon how much medicine you can afford. If you do not have money, you do not get referred to the specialist. You don't necessarily get the same doctor or the same care or the same treatment as someone else may. A little story about this. When I first graduated from undergrad, I had been fortunate enough, I had military insurance through my parents, and then I had the health clinic that was on my campus, and then for graduation, I went to Miami, because that's what you do when you graduate undergrad. You go to Miami, and you get on a jet ski, and I fell off. So I'm not good at jet skiing, in case you didn't get that from the story. So I fell off the jet ski, so I did what I always thought you do. You go to the emergency room. I went to the emergency room, and the doctor said, "Oh, you don't have insurance." I said, "No, I don't have insurance, but I do have an ankle the size of a grapefruit right now, so I'm thinking something isn't right." So then she tells me, "Well, it's probably not broken, and, x-rays are very expensive." So she gave me an ACE bandage and a pair of crutches and some ibuprofen. Now, I know we have some health professionals in the room. What do you think of that? Do you think everyone would have been treated that way? If I had insurance, she probably would have taken me back to an x-ray right away. She probably would have found the 2 fractures in my ankle, and I probably would have had a cast instead of an ACE bandage, some ibuprofen, and some crutches. Did not. So I ended up walking with a limp for 2 months until I got myself to a specialist after I got health insurance. What else contributes to health disparities? Education. Education is one of those long-term factors when it comes to health equity. We know that how much a person goes, how far they go in education does definitely increase their positive health outcomes. If you're lower educated, if you're less likely to graduate from high school, you're less likely to access preventative care services. We see education as being really one of those dividing lines when it comes to health equity, because you can literally look at someone and say, as their income level goes up, as their education level goes up, their health outcomes improve. Poor housing, living in neighborhoods that make you sick. We see this so much, unfortunately, as we look at health equity. We have some communities that, you'll have children who have asthma, but they live in low-income housing with smokestacks nearby. If you're not used to working with children with asthma, smoke plus asthma is not a good mix. Or we see women who have children who live in homes with old carpeting, homes that have mold or mildew in them. So their homes are actually making them sick. The place that should be making them feel safe makes them sick. Neighborhood segregation. You have the poor side of town. And the poor side of town has poor side of town services. Where you go to more affluent side of town, you see different services. The physical environment, and definitely failures within the healthcare system. We have to be realistic and understand that our healthcare system does not treat everyone equally, and we need to ask ourselves what we can do to improve that. So who's affected by health disparities? Racial and ethnic minorities, including immigrant and refugee populations. Always one of the first groups that we see health disparities come out in. People who have English as a second language. Residents of rural areas. If you're in a rural area like where I originally grew up in, you know, the closest hospital is 30 minutes away. If you don't have a car, how do you get to the doctor? You have to make sure that that doctor's visit is really important before you go. You have to make those kind of choices based on where you live. Women, children, the elderly, and persons with physical and mental disabilities are also affected. So a little bit about cultural and social influences on healthcare. The social and economic environment of health inequality definitely impacts some of the health disparities and health inequities that we see. Unfortunately, as I mentioned before, if you look at society, we're kind of socialized to think, well, I don't have insurance, so I can only go to the public health hospital. I can only go to the community safety net clinics. I can't go to a primary care doctor. This is some of the things that healthcare reform is looking to change. Greater exposure to racism, discrimination, violence, and poverty, mistrust of the system. Really interesting thing about the system, notice I have that in quotation marks. I was doing a research study with some African-American men in Elyria, Ohio. It's right outside of Cleveland. And when I came down and said, hey, we're gonna do a research study with you, we're gonna talk to you about your high blood pressure levels. They said, well, I'm like, and then I say, I need you to sign this informed consent form. So they're looking through there and they said, informed consent form, research. Is this gonna be like the Tuskegee experiment? And if any of you are not familiar with this, you really should be. The Tuskegee experiment, where essentially African-American men were purposefully injected with the syphilis virus and then denied treatment even when they already knew the cure for the virus was available. They went a step further and told local hospitals, men who are in our study should not be seen even if they come to you because it'll mess up our research findings. Now, this is just one of the numerous things that has happened in the history of research. Unfortunately, even though this may have happened generations ago, you may think, this still impacts what we see today. Ethnic and racial minorities are less likely to participate in clinical trials because they may know nothing else about research, but they've heard of these types of experiments. So they're kind of distrustful of the healthcare system. So it's our jobs as health professionals to make sure they understand that we're going to be culturally competent, we're going to be respectful of the people that we see, and we're going to understand about their desires and their needs, as well as some of their misgivings about coming into a doctor's office or any type of medical setting. And also clinical environments that do not respect or are incompatible with the cultures of the people that they serve. This is very important to think about when you're talking about health inequity, because when you're going into a clinical environment, no one likes to go see the doctor. So you're going in there and you're nervous, and then you're with someone who does not necessarily respect you or the culture that you're from, because they want you to be respectful of them. They want you to do things their way. Their way. We were doing a research study also with a bunch of dentists, and the dentist said, you know, the reason why I don't see a lot of Medicaid patients is that I don't have a big enough waiting room. They want to bring their whole family with them. I'm there to clean the mother's teeth. I don't have room for all the rest of the people. That's not a very understanding cultural environment, because if you have 3 children who are all school age and you need to go to the dentist, what are you going to do with your children? You can't leave them at home. You also, let's say you're low income, so you don't have a car. You got to take 2 buses. So that means now to have that one oral care visit, and we're telling them to go twice a year just for preventative treatment, they have to miss a day of work, take their children out of school, take 2 buses across town. So yes, their 3 children are going to be in the waiting room because that's the only place they have for them to be. Cultural environments have to be understanding and respectful of the fact that this is one of the barriers people have is childcare, so children may be coming with them. Also understanding family engagement and family environments. In some of our cultures, you bring your family with you to the medical appointment. We actually have a lot of initiatives in the Black community, like Bring Your Loved One to the Doctor Day. So I'm gonna bring my grandmother to the doctor, my grandmother's gonna be there, I'm gonna be there, my mother's gonna be there. There's only one patient, but then again, we wanna make sure we're understanding what she needs to do. This is the way we care for our elderly people. That's part of our culture, so we need to make certain that our clinical environments are understanding of the needs of our communities and understand that, yes, we may have some extra people with us, but that's the way that we're gonna be able to really diagnose and understand a lot of this health information. So that brings me to cultural competence. Cultural competence is really the goal. We've done so much research at Morehouse School of Medicine asking people, do you want a doctor who is from the same racial or ethnic or religious or group as you? And a lot of times what we found is what they want is someone who's going to be respectful of their culture. So what that means is you don't have to be a person of color to treat people of color. It also means that you have to make certain that you're understanding and respectful of the communities that you are serving. Cultural competence is really the cornerstone of what we need to strive to be as health professionals. There's a couple of risk factors for inequality, access barriers. I'm sure you guys may have seen this, language. Health literacy is a very big one. As soon as you go into a doctor's office, we hand that packet of information, and as a person who does evaluation, I love those forms. I have so much knowledge about these people. But now we've set them down and we've given them a clipboard of 14 pages and a pen. And we say, come back up here as soon as you're done with this. So if someone has literacy issues, how long does it take them to get through that form? And how are we making sure that we're checking to see if they are able to understand what's going on there? What language is that form in? And all the questions about family history using these very big words that unfortunately, and I can tell you in Atlanta, when I'm talking to people about diabetes, I'm talking about their grandmother's sugar levels, because that's what they say. My grandmother has the sugar. So then when you start talking to them about diabetes, they're like, is that like the sugar? I can talk about hypertension all day long, but until I said high blood pressure, I realized I was talking to a group of people that did not know what I meant because that's not what they refer to it as. So while we have our clinical skills and our technical knowledge, we have to make sure that we're able to break this down into a way that the community is able to digest. And also, don't be afraid to teach new words. Don't assume because someone didn't know something the first time or someone has an accent, that means that they may not understand anything that you're saying. We have an opportunity to really create educational opportunities in clinical environments by looking at what we're asking people and what we need it for and explaining our needs to them. Lack of insurance, a source of care, lack of financial resources, and legal barriers. Citizenship status is also a growing issue while people are afraid to go to the doctor because they're afraid of, will you be looking at my citizenship status? Will I be turned in? What does this mean? So you have to make sure that you're letting people know that your offers of education or help are not contingent upon their citizenship status. You're here to make sure we have healthy people regardless of what their green card says. Here's an example of access inequality. As I mentioned before, I have the opportunity to work kind of nationwide, and in Ohio, they have some wonderful programs that are targeting African American men and really using integrated healthcare. So we did some key informant interviews, and I talked to one of the health providers, and I said, can you let me know what access inequality looks like in Elyria, Ohio? This health provider, who is a doctor, he said, they have to buy medical supplies, medicine, testing tools, and pay for doctor's visits. Then they often have to choose between medicine and food. When they do not have insurance, they often hide the true impact. We have people in our communities that are having to pick between, am I going to eat today, or am I going to take my chronic disease managed medication? Am I going to take half a high blood pressure pill? Am I going to pay my heat bill, or am I going to refill my medication? Unfortunately, when you have medication that is necessary but is also unaffordable, you're running into an access issue. And what we end up seeing is poorer health outcomes. Another risk factor for inequality is cultural barriers. a lack of knowledge about the healthcare system. We do have a lot of specialist providers and a whole lingo that we use when we're talking about navigating systems and needing referrals for care that unfortunately people in the community who do not live and eat and sleep and breathe this world every day do not necessarily understand. And this is just not something for new populations coming to the United States. I work with people who are 5th or 6th generation Georgians who still do not understand exactly how to navigate the healthcare system. It's hard to be a patient these days. You have thousands of medications. You have warning labels you may not necessarily understand. I actually had a woman bring me a letter. She said, this lady said that she wanted us to help her with her medication, and she showed me a picture of a label. It looked like a man who was growing, and then it looked like he was getting bigger, and I was like, this medicine turns her into the Incredible Hulk? I don't understand. And then it turns out that the label actually said for external use only. But because she did not know what that symbol meant, she just didn't take the medication. So again, we have to make sure that we understand the patient-doctor communications and we're understanding exactly what we're saying. Also there's one big cultural barrier, which is perception of need. We may know as health professionals that this is a needed service. Annual checkups, yes, that means we're asking you to go to the doctor even when you think you're healthy, are a needed service. Cleanings, preventive care, are a needed service. But there can be completely different perceptions of need based on a society or their culture. In the African American community, we do a lot when it comes to like mental health, for example. People who may have diagnosable mental health diseases, they say, well, all I need to do is pray it away, because that's the first line of defense in that culture. We have other cultures that think men don't need doctors. As soon as I can't get up to go to work anymore, then I'll talk about it. So what if I can't, at the end of the night, I almost collapse due to the weight on my back? I'm not going to a doctor. I'm a man. Men don't need doctors. And a lot of stigma around having mental health issues. And I know for some of our populations that we work with in Atlanta, we work a lot with the Somali population. And we have women who say, by having a child who has some sort of special needs, they're ashamed to take them out in the community because of the stigma and what it means for their family. So how can we make sure that they don't feel isolated and that family is getting the supportive services that they need? And also it's the perception of cultural inequality, the perception that healthcare providers are going to treat them differently. I have an example for that. We actually were working in Columbia, South Carolina for a program called I Am Woman, and it's a nutrition and education program targeted for African American women who have some sort of, or either have diabetes or are at risk for developing diabetes. And one of the women said to us, I don't want a smaller room or an intern. I want the same service as everybody else, even though I'm not able to pay. When I go to the doctor, I don't want to be looked at as a lady in 2B with no health insurance. This is her perception of being a Medicaid patient in a healthcare provider's office. So when you think of this lady here who already believes that she's going to be getting the student doctor and the inferior care, is she going to be trusting some of the outcomes that come out? How is she going to feel about some of the results? How is she going to feel about how much she should adhere to some of the health care plans that were provided to her? Some other factors for inequality: structural barriers. I could really talk a long time about some of the structural barriers in the way that we set up our healthcare systems, because this is something that we really have to look at. Long waits. I made a doctor's appointment for 1 o'clock, it's 2:30 and I'm still waiting. Maybe none of y'all have had that experience. Or how about the fact that you have people who have to take off work to get there? This is why they end up taking off a whole day of work, because long waits in the emergency rooms or long waits in the hospital. Inconvenient hours. Inconvenient hours. Trust me, I love the fact that I can talk to you guys at 2:30 on a Wednesday, at 12:30 on a Wednesday. I love this. I love that by 2:30 I'm going to be done. That's fantastic. But for people in the community, they have jobs. They're working the same time you are, so extended office hours can be the difference between someone seeing a preventive care professional or ending up in the emergency room for some sort of advanced need later on. Lack of transportation, the way we build up our cities, and the high cost of services. An example of structural inequality from Buffalo, New York. It was an African-American female. She's a grandmother who's a primary caregiver for 5 children. This is what she said. She was basically trying to tell us about how she's been trying her best to do everything that a healthcare professional has told her to do. They tell me I need to go to the doctor. for my diabetes. So I make an appointment to go. I take a day off of work, take 2 buses and get there. I get there and they tell me I'm late, so I gotta wait. Then I have insurance, but I still have to pay. Then I leave with medicine that costs over $85. I had to miss work with no pay. How am I supposed to afford $85 on my budget? So I stopped taking the medicine when the sample ran out. Who has money for that? The reason she's in here as a quote is not only did she tell an example of taking transportation barriers, having cost barriers, having to wait because her bus was late, she didn't take the medication that was necessary. She stopped taking her diabetes medication. By the time she got to our program, she was feeling tingling in her left foot. We had screenings, so we took her immediately to the emergency room. She ended up having to have 3 of her toes amputated 2 weeks later. This is what health inequality looks like. When you have someone who still has care but is unable to afford it, when you have someone who's taken all the steps they need, went through all the hoops to get to the doctor's office but still had to wait, our healthcare system, unfortunately, isn't set up to necessarily address the needs of this woman. So that brings us really to how the social determinants of health really impact help-seeking behavior, and they lead to health disparities. That's the overarching thought I want to make sure everyone understands. That when we don't address some of the underlying causes, when we're not making sure that we're culturally competent, when we're not making certain that we have transportation to healthcare centers that are open at convenient times to the community, when we don't make certain that people can afford to live by the prescription plans that we give to them, what we end up with is health disparities. Now that's all the down stuff, but how can we address it? How can we address health inequality? There is a lot of approaches that we can use, but the basic thing we can do is look at community engagement, culturally competent interventions, and community-wide policy change. By going through these 3 steps, we're going to be able to address inequality on a local, and a community-wide, and a nationwide scale. So a little bit about community engagement. The first thing you got to understand is that when it comes to community engagement, the first rule of community engagement is shared goals equals equal outcomes. You got to make certain that you have the same goals as the community that you're looking to serve. I know that we can all go in and pull up some BRFS data, and then we can get the census tracts, and we can do the overlap with the GIS mapping, and then we're going to do our community needs assessment, and we're going to determine that the people in this zip code need this intervention. But what if the people in the community don't think that's the thing that they need to work on? What if there's not interest in that topic area? I can't tell you how many times we went into an area saying we're going to talk to people about, and they said, oh, you're going to talk about HIV and AIDS, right? We're like, no, that actually wasn't what we were going to talk about, but I guess now we need to look back at that. You have to make sure you have community input so you can make really smart, strategically targeted interventions. Checks for equality. Cross-sectional partnership development. Partner with the community that you wish to work in. That is so novel of an approach, and trust me, I've literally made a living off of telling people you should partner with the community that you wish to work in. Because people in the communities are the front line. They know exactly what the needs are. They know exactly where the resources are. They know exactly where the people are. So you need to make sure that you have partnerships that don't just include medical professionals. And establishing a connection based on those shared goals. The next thing you got to worry about is culturally competent community-based interventions. I love community-based interventions and CBPR because I believe that the best way to have outcomes is to make sure that you're founded in science, but that you have community engagement and you're setting your programs up directly where people are. So through this, you can do a lot of different things, such as consistent racial and ethnic data collection. Funny story about consistent racial and ethnic data collection. The behavior risk factor survey, it's kind of our holy grail in public health because it does a survey of all these people in each state and it asks them a whole bunch of questions. However, this survey is a phone survey on landlines only from an unknown caller. How many of you would answer the phone if you saw a call coming in from an unknown caller and the person answers and says, oh, I want to ask you a lot of personal information about your lifestyle habits? That sounds a little suspicious, a little sketchy. So unfortunately, racial and ethnic minorities are less likely to participate in this survey, so we're underrepresented in all of the categories that they actually assess. So we have to find a better way of even collecting data on some of these cultural and ethnic groups. Minimum standards for culturally and linguistically competent care. Unfortunately, we have to understand that, you know, your office may not be set up to handle everybody, but you should have a resource to link you to someone who is. Because we have people who are in this country who do speak English as a second language and may be more comfortable speaking in a different language. How can we make sure that we're reaching out to them and we're serving their needs as well? And increased minority representation within the workforce. When you have more diversity, you end up getting a different set of ideals, a different approach also to interventions and what can be best used. And one of the things I definitely got to stop on for a moment for cultural competency is creating outreach and educational programs that utilize community health workers. How many of you know what community health workers are? Great. There's some in the room. Can we give them a round of applause? Community health workers are wonderful. The beautiful thing about community health workers is that most of the time they're lay members of the community. They come from where you're trying to serve. Community health workers can work in a whole variety of settings, but the beautiful thing about community health workers is that they are proven to reduce health disparities, because community health workers can go beyond being linguistic interpreters to actually break down the cultural divide when it comes to health medication instructions, care instructions. They're wonderful if you're a researcher and you're looking for case finding. I can't tell you the number of times that I've needed to do a study of, you know, women who come from Somalia who between the ages of 34 and 54 who have a biological daughter who's between the ages of 8 and 12. That's a very steep ask. But guess what? I was able to go to community health workers who were able to find me 12 women who met that criteria. And if anyone's into research, you would understand that's a very big lift to make. Translational research can happen as a result of community health workers. We spend a lot of time doing research, and I love our peer-reviewed journals and publications, but a way to make sure that the information that we're talking about is broken down and actually disseminated back out to the community so they know about new changes, they know about findings. This is a wonderful way to utilize community health workers as well. Not to mention, when you have people disseminating information and talking about programs and talking about opportunities who come from the community that you're trying to do outreach to, you end up having greater success. We've seen programs with community health workers end up having a 92% retention rate over 3 to 4 months. That is amazing, when we're normally used to losing over half of our population within the first 3 weeks. Just because you have that one person who says, I care about your health, I'm from the same background you are, and I think this is something important that we should be engaged in. Expanded access to service is another way that we can definitely engage in culturally competent based interventions. When you expand access to service and you expand access to care, you always see health disparities drop. And this is another plug for Medicaid expansion, because then when people have a medical home, which is what we should be striving to, people should have a medical home, people should have a dental home. So if you have an oral health care home and a medical home, you have someone who can track your progress, your health status, your outcome, someone beyond the emergency room doctor who can say, this is where you were a year ago, here's where you are today, I'm seeing some things here we may need to address. Those things can only come when you have a relationship with your provider. Another thing that we can always do is have more involvement of all healthcare system stakeholders and in minority improvement and action. We think it's the goal of all of us as health professionals to make certain that we're being culturally competent and we're reaching out to other communities. The next thing we always want to do is community-wide policy change. You can follow this graphic up here about policy change based on needs, but I want to give you a real example of this. In South Carolina, we had a group of women that we were talking to about nutrition. And one of the things we always say is when you've got to talk to someone about nutrition, the first step is fresh fruits and vegetables. The next step is physical activity and exercise. Reduce your stress and repeat. However, what we also learned is that if you live in a community where you're telling people to get fresh fruits and vegetables, but they live in a food desert. What I mean by a food desert is that there is no grocery store or fresh fruits, vegetables, or produce that is found within a 3-mile radius of where they live. So if you want to actually have a pear, you have to go 3 miles away from your home to get it. And again, keep in mind, we're talking about people without cars. So that can end up being a whole different bus line just to get fresh fruits and vegetables. Then we tell them you need to exercise. The women in our I Am Woman program lived in public housing, and they lived in a community where there were no lights at the playground and there was no lights along the walking trail. Now, the city did agree to put in a walking trail, but there's no lights around it. So how much do you think that walking trail was utilized? The women came to us and they said, I would love to go walk, but I'm not going to go walking in the dark through the woods in this nice little nature trail that the city has put up. Yes, that's poor city planning, but also that's also a public health issue because we're talking about safety. Safety is a public health issue. So the women in our community said, well, what can we do to help make some changes around this? So we actually talked them into going to the city council in Columbia, South Carolina, and say, we want to get street lights put up along the walking trail so we can use the walking trail after dark. And they successfully got 4 street lights put up along their walking trail. These women, they don't realize what they did, but they actually went through all the stages of policy change that you learn in public health because they realized there was a problem. The community was in support of addressing the problem. It's highly changeable. It would make a very big impact. They realized that, looking at where the street lights needed to go so that there could be utilization of this train, they found the win-win. You get to say, hey, we're utilizing this park that the city had spent money on, and the people in the community had an opportunity. Definitely looked at policies for inequitable treatment because one of the things they talked about is how come all of the city's trails that were placed on the north side of Columbia had lights, but the ones on the south side of Columbia did not. Inequitable treatment. They built a broad-based coalition of citizens as well as their city council member, and then they went ahead and testified before the city council member and got the change that they sought. So they went through all the stages of policy change. But next thing I want to talk about is how can we really promote health equity together? What we can do is educate. Educate people on what makes a healthy community. Does everyone have equal access? When looking at health programs, I think another thing we have to remember is people are free-range people. No one lives inside of a clinician's office. They come out and they have to interact with so many social determinants across the way that we need to make certain that we're looking at how this recommendation can be applied to them. Analyze policies for change and equitable treatment, and support policies that will create healthier communities. And I want to make sure that you understand what I mean by supporting policies that create healthier communities. I'm not only talking about straight Medicaid expansion policies, I'm talking about a lot of other things. Education policy is health policy. When you make policies about schools, when you make policies about class sizes and you increase the likelihood of an individual graduating from high school, you're increasing their educational attainment, you're increasing also their earning potential, and you're decreasing their health disparities. Economic policy is health policy. When you increase the minimum wage, not just for federal workers, but for everyone, you end up making, I'm not going to get in policy too much, but I'm just going to plug that for minimum wage increases. But when you do increase the minimum wage, you end up increasing an ability of an individual to support their family, the ability for an individual to afford medication. You end up increasing their likelihood of having positive health outcomes and decreasing health disparities. Child care policy. This is something we see a lot. Child care policy is health policy. When you're making rules and regulations around the keeping of children, where children need to stay during the day, and you make sure everyone has to stay in a licensed daycare facility that charges $200 a week for someone who only makes $350 a week, you've also created a health disparity. If people can't have someone to watch their children, they can't work. When they can't work, poor health outcomes. Transportation policy is health policy. Deciding where bus routes go, where they don't go, or in the neighborhoods that I'm working in now in Columbia, since they got the street lights, they're all policy champions now. They're actually working on covered bus stops. It may seem like a small thing, but the ability to have your children in a stroller at a bus stop that is covered on a very, very rainy day in Columbia, South Carolina makes a huge difference. Also, it decreases colds. It's very big during cold and flu season as well. We want to make sure people are getting their, their flu shots, but we're letting them stand in the rain to get to our office to get one. So when you think of community health and policy development, when you think of community engagement, I really do hope that you think about how we can definitely move towards empowerment. The individual, the society, and community-based programs collectively really is how we can move health quality, improve the quality of health and move health equity forward. We want to make certain that we look at inequitable treatment. We want to make sure that we're looking through a cultural lens of the people that we're trying to serve. And we also want to make sure that we're standing up for an inequity whenever we may see it. I'm going to leave with one more quote by Dr. King, and this is something that I think I've lived my life by, which is, our lives begin to end the day we become silent about the things that matter. Think about what matters to you, and think what matters to the communities that you hope to be serving as soon as you get out of school here someday. Don't stay quiet about inequity. Think about ways that you can personally address this. All right, thank you.
Great, thank you so much, Starla. When I was calling down to find out about if Starla could come or not, I was talking to one of her colleagues, and I was asking a little bit about her, and she said, you want Starla, you want Starla. She's so passionate, she's so energetic, and she's such an expert in the field, so thank you so much for being here today. Some of the students might need to leave, but I'm sure there's some questions, so we're just gonna kind of open it up to the floor for anybody who would like to ask some questions.
Hi, my name is Michelle. I have a question about culturally and linguistically appropriate evaluation. And you do a lot of evaluation, and I sometimes get frustrated by that evaluation often can't show what needs to be shown because it's driven by scientific rigor, and how you balance the two.
That's a very good question, because we do have our scientifically sound principles that we want to use with evaluation, but we want to make sure that they're culturally appropriate. Sometimes some of this comes down to the way that you're going to be asking and structuring questions. I can't tell you the number of surveys that I've read who have used words that may be confusing, but what we want to make certain that we're doing is asking things also they're in a private manner, especially if we're talking about women's health. So when we're talking about women's health particularly, what we normally try to do is make certain that we know from the culture they're coming from what topics may be taboo to be discussed, and then put those off to a separate for an interview or one-on-one situation. We do so many key informant interviews, one-on-one interviews, in addition to making everything being written, because some people may not be as comfortable with having different information written down. So that's one of the ways that we make sure that we're being, culturally competent with some of our evaluation. Any more questions? Comments, jokes? Okay, in the back.
Oh, thanks. Hi, I'm not a healthcare provider, I'm a librarian, but I wonder if there is research that compares within the same community one group of people who are given every single thing that they need for their health compared to those people who have so many barriers. Is there research that compares the outcomes?
There is comparative outcomes within the same community. Dr. Troutman, who was past president of the American Public Health Association, has wonderful research on inequality within the same cities. Because what we found is if you take a city and you divide it in half, there's normally some sort of dividing line. And when you look at that dividing line, you're able to say, these people live within the same area. I think one of the areas I know he did research on was Louisville, Kentucky. We've also seen it in some other areas. On one side of town, you will see places where people have access to fresh fruits and vegetables. They have grocery stores on every corner. They have, health providers on every corner. They have parks. They feel safe walking their children or dogs in that park. And then you'll see on the other side of the city, research has shown that you go on the other side of the city, and the next thing you start seeing is check cashing places and liquor stores on every corner. You no longer see, fresh open-air parks around. You see dilapidated structures, which people aren't using it. So what they end up looking at is people who are the exact same age, who live in the same city, and when you control for where they live, you can really determine some of their health outcomes. Place really does matter. With real certainty, you can go down to where a person's census tract is and tell, unfortunately, what their quality of life will be in the rest of their life. So there's lots of research that's been published actually in the American Journal of Public Health around that topic. Any other questions?
I too am, I'm becoming a health professional. I'm trained as an anthropologist, and so my question is cultural in nature, and it has to do with the terminology, health equity versus health equality, because equity and equality are different. Like equity is about fairness, right? And equality is about being equal. And so I'm curious about the choice of language around equity, because all concepts are socially constructed, but fairness can really be be misconstrued, can, you know, can be turned around. And so I'm really curious about the use of equity as opposed to equality.
Equity versus inequality.
Yeah.
We normally run into equity versus inequality and health disparities, kind of the difference between that. When we talk about inequitable treatment, what we're talking about is the systemic factors of the system. Once a person comes into contact with the healthcare system, how are they treated? How are their outcomes? You know, are they receiving the same referrals as someone else? Because what we've seen is a lot of studies that have shown that, you know, for example, when it comes to breast cancer, African American women are less likely to be referred for diagnostic follow-up treatment. So we're starting to say the different sexual inequality and things that come out of outcomes of actual health interactions. And when you're talking about the fairness of it all, that really is a subjective term. Different people have ideas of what is fair and what is necessary. So what we really do try to say is that, do we have equal access to this system? Do we have a minimum basic standard of care that every individual should be able to be able to access? And if so, once they receive that care, will they have the same career path? Will they have the same, referral path? Will they have the same outcomes? Will they get the same information once they access that system? And unfortunately, our current health care system is not always set up to be the most equitable. Any other questions? One more thing I want to talk about with health equity. A lot of times this comes back from an original issue of discrimination that has occurred, that has transferred on for generation upon generation. That cannot be ignored. Dr. Kamara Jones, one of my colleagues, she always tells this gardener's tale. Have anyone heard the gardener's tale? About how things grow from a seed that was planted in a different box a very long time ago. Unfortunately, what we're still seeing today is the sprouts from that inequality that occurred generations ago. So what we need to make certain that we're doing is really being able to address the current system, what we can do as health professionals or future health professionals, and how we can bring equality to all healthcare systems. Thank you very much for your time and attention.